Good afternoon. Today we're going to talk about local anesthesia as per the table we set. So, today's topic we will talk about an introduction, mode of action, the techniques of anesthesia, the drugs that we use, complications, and so on. Now, what is local anesthesia? Local anesthesia it's a state of reversibly numbing the pain, loss of sensation in a specific area. So, in a specific area of the body, we just do loss of sensation in this area without loss of consciousness. So, the patient would remain conscious, the patient would remain able to accommodate orders, anything we say, verbal orders, anything we say to the patient, he will understand it. He's still awake. Only the area that we want will be anesthetized, meaning it will be loss of sensation. Nothing the patient will feel in that area. Okay, now we'll talk about some terms. Now, anesthesia, absence of all sensory modalities. Paresthesia, it's an abnormal sensation, tingling, whether spontaneous or evoked, meaning we have an abnormal sensation, tingling, something moving in the hand when we sleep on it. Now, this can be spontaneous without any preceding factors, or we can activate it and make it happen by, of course, sleeping on the hand and so on. Hypoesthesia, diminished sensitivity, diminished sensation. Hyperesthesia, excess sensation. So the patient will feel very slight, patient will feel a lot of sensation. Even if the cause does not cause that much of pain or doesn't cause that much of sensation, he will feel it very minimal of it will cause a great sensation in the patient. Dysesthesia, it's an unpleasant abnormal sensation. Now, meaning it can be tingling sensation, it can be burning sensation, it can be any kind of sensation that the patient might feel, whether to painful or non-painful stimuli. Okay? These are some of the terms that we have. Now, the mode of action. Usually, as we all know, sodium is present excessively in the extracellular fluid. Intracellularly, we have potassium. Now, we have voltage gated sodium channels. Once these voltage gated sodium channels open, or a voltage change happens, they will open. They will allow sodium to get into the cell and potassium to get out of the cell. Okay? This will cause the sensation, the pain. Now, with the action potential and so on. Now, what happens when we give local anesthesia? There will be inactivation. There will be prevention of the sodium transfer. So the gate is open, but we have no sodium moving into the cell or out of the cell. Okay? Now, the armamentarium that we have for the local anesthesia, we have the syringe itself, we have plastic or metal. Now, the plastic syringe sometimes can be used in patients with hepatitis B, so we do not cause any injury or we don't transfer an infection even with sterilization and so on. Sometimes the plastic syringe can be used. Now, it's mostly used for insulin syringe, for example, for insulin for diabetic patients. It can be used for injections, IM injections, and so on. The metal syringe mainly used for our work. We have the local anesthesia itself, and we have the needles. Now, the needles we will find that we have long and short. The long ones are used for the infraorbital block, for the inferior alveolar nerve block, and so on. The short one for infiltration. We have the gauge. Now, the gauge is the diameter, or opposite to the diameter to be specific. As the gauge increases, the diameter decreases. So, a 21 gauge needle would have a large diameter. It will be painful. A 27 would be less painful than the 21 and easier to penetrate the tissues and thinner. The 30 would be even less painful and thinner, than the 27. They tried to make it to have a larger gauge, but they found that then we have the risk of breakage of the needle. So they stuck to the 27 and the 30. They found that it's less painful than others, and the needle itself remains strong that we can use and without the risk of breakage. Now, the syringe we can have aspirating syringe, non-aspirating, or self-aspirating. Now, it has the hub, the piston, like a pistol, the barrel, and the harpoon. Now, the aspirating syringe has a harpoon. This harpoon, once we do the opposite movement. Now, when we want to give anesthesia, we push the thumb ring. When we want to aspirate, we push it backward. We find if there is blood, this means that we are on an artery. This can raise the blood pressure. This can cause arrhythmias. So we can change the position that we're giving in. Now, the non-aspirating does not have that feature. So if we are in a vessel, we will not be able to know until after we have given the anesthesia and we find blood in the carpool or the ampoule. The self-aspirating, it aspirates by itself, and you find that it has, of course, a harpoon, and you find no blood, and you give. Now, the contents of the local anesthesia itself. The contents contain the local anesthetic drug. Now, some local anesthesia have vasoconstrictor with them. Now, the vasoconstrictor is placed for four main reasons. Number one, once you give plain anesthesia, it will cause bleeding because you insert a needle in a place, any place in the body, it will cause bleeding. This will cause the blood circulation to come faster, and this will cause wearing off of the anesthesia much faster, and you will need to give multiple doses. So they found that if we add a vasoconstrictor, this will cause longer duration of the anesthesia. Number one, this will cause that we can give more anesthesia without the risk of toxicity, reducing toxicity, because we will give anesthesia, it can remain for 1 hour, 1 hour and a half with the vasoconstrictor. Without the vasoconstrictor, it can remain for like 15 minutes, 20 minutes tops, okay? So they found that we can have longer duration, less toxicity because we will not need to give more anesthesia. We can have more material, more the anesthetic agent in the carpool. So this will give us a longer effect or a better effect, more anesthetized effect, because we have some part of it, we can, the carpool itself is 1.8 milliliters. So instead of 1.8 milliliters only anesthesia, risk of toxicity, it will cause that we have less amount of anesthesia, that we can give 2 or 3 carpools without the risk of toxicity. And this will cause vasoconstriction at the site of the injection, which will reduce the amount of blood coming to the area, causing less bleeding. So less bleeding, less toxicity, longer duration, more anesthesia. Reducing agent used to stabilize the vasoconstrictor so it doesn't get oxidized. Preservatives. Now these are the ones that cause allergy in some patients. fungicides, and isotonic solution. Now, most local anesthetic agents are tertiary amine, and the primary target is voltage gated sodium channels. We have short duration or moderate effect, long effect. The procaine, for example, an we have two types: ester and amide. Ester is usually metabolized in the blood. Plasma cholinesterases will metabolize it. Now, mainly the way to know it, we have one I: procaine, chloroprocaine, cocaine, and so on. These will be short effect because we don't have because the blood will come and they will break them down, so it will be of short effect. They found only that cocaine is the best one of those because it has a vasoconstrictor with it without the need of addition of a vasoconstrictor. So it can have a longer duration than others. Moderate effect like lidocaine, mepivacaine, prilocaine. Long effect like tetracaine, propivacaine, and etidocaine. Okay, now the potency of the local anesthesia is regulated by lipid solubility. The more lipid soluble the agent, the more potency. Potency means the amount of drug that we need to have the effect. So, if the drug is lipid soluble, it will be soluted in the lipids faster. This will cause less amount of the medication to cause the effect. The time of onset by the pKa of the substance. The duration by protein binding, because there will be more drug present in the body, reserved in the proteins, so it will be longer duration. The more lipophilic the agent, the more potent it is. Now, we have topical anesthesia, infiltration, regional block, and supplemental anesthesia. Now, the topical, we use it in kids to lessen the discomfort of the needle penetration. Now, for the block techniques, it doesn't help that much. We can have creams, ointments, sprays. We can have lidocaine, benzocaine. Now, the main one used is Oracix. It's combination of lidocaine and prilocaine, and it has different flavors: bubblegum, strawberry, mint. So you can use it. Now, infiltration mainly for the maxilla and for dental pulp anesthesia or extraction, and for the mandible in children. We need the patient to be partially opened. We drop 1 to 2 millimeters of the solution at a rate of 30 seconds per milliliter. Now it's supraperiosteal, meaning we don't have bone touch here. You just give it at the site. Now it can have 45 minutes as a working time for us to do a procedure, and the patient may have subjective anesthesia for like 1.5 to 2 hours. So it's good. Now, let's talk a little bit about the nerves. We have the ID nerve, which comes from the mandibular nerve, from the trigeminal. Now we have the fifth cranial nerve, is known as the trigeminal nerve. It has 3 branches: the ophthalmic nerve, which is sensory; the maxillary nerve, which is sensory; the mandibular nerve, which has sensory parts and motor parts. The motor parts for the muscles of mastication. Now, for the mandibular nerve, for the maxillary nerve, it comes out of the foramen rotundum. For the mandibular nerve, it comes out of foramen ovale from the skull. Now, anyway, it gives us the ID nerve, which supplies the pulp of all the teeth. It then goes out from the mental foramen to become the mental nerve, giving us the 4 and the 5 and the 3. Then it goes back into the nerve, into the bone by the incisor foramen, giving us the innervation for the 1 and 2. We have the long buccal nerve to supply the buccal tissues on the molar side. and the lingual nerve to supply the lingual tissues and the anterior two-thirds of the tongue sensory-wise. Now, the lower lip is by the mental nerve as a sensory-wise. Okay? Okay. So, for the maxillary part, we have the maxillary nerve, which goes into the posterior superior alveolar nerve, which gives us innervation buccal and pulp to the 8, 7, and 6. 8, 7, 6, without the mesiobuccal root of the 6. Now, the mesiobuccal root of the 6 is supplied by double nerves, the posterior superior alveolar nerve and the middle superior alveolar nerve, which supplies the 4 and the 5 as well as the mesiobuccal root. So always we try to give the anesthesia at the 6 and then more towards the 5 to prevent the pain from happening in these patients. Then the anterior superior alveolar nerve, which supplies buccally, the central, lateral, and canines. Palatally, the the foramen incisivum or the nasopalatine duct. This gives us the nasopalatine nerve, which gives us palatal innervation from the 3 to the 3. From the 4 to the 8, we have the greater palatine nerve, and the opening appears distal to the 6 and the 7, about 1 centimeter. Okay, so actually mesial, it's closer to the midline. Sorry. Okay, now most of the time in any patient, we need to give more anesthesia in the center because it sometimes has supplemental anesthesia or collateral innervation. If we're doing the central endo, for example, the patient might still feel pain, so we need to give anesthesia to the left or the right central. So if we're doing the right central, we need to give anesthesia at the left buccally, so to prevent the collateral innervation. Now the facial nerve. This is the ophthalmic, the trigeminal nerve. Okay, so these are the branches of it: superior alveolar nerve, superior dental plexus, buccal nerve from the facial, and so on. Now, for the posterior superior alveolar nerve block, for the molar teeth, and 20 millimeter penetration, and that's how we give it, nearly at the tooth, buccally. The middle superior for the premolars and the mesobuccal pulp of the permanent first molar. For the anterior, for the canine and the incisors. So here to anesthetize the central lateral canine, and here for the 4 and the 5, that's where we give our anesthesia. Now, the regional block, ID nerve or inferior dental nerve anesthesia. Now, we give it in the pterygomandibular space, in the medial aspect of the ramus. We anesthetize the teeth, the bone, the soft tissues of the lower lip, and the gingiva. The most common problems, either we contact bone too soon and this will give us failure of the anesthesia, or going too posterior and this will cause facial paralysis because we entered the parotid duct. We went more superior. Okay? Now, lidocaine with epinephrine would anesthetize the tissues for around 45 minutes and can remain for 3 hours for subjective, when long-acting solutions can remain for 6 to 8 hours. So here how we give it, around 6 to 10 millimeters above the occlusal plane. Now, the boundaries that we have the medial pterygoid making the floor and medially, the lateral pterygoid making the superior border, the lateral border of the ramus making the anterior border, And posteriorly, we have the parotid gland, and that's where we give it. Sometimes we need to, if we want to anesthetize the whole mandibular nerve, we can go for the Gauge technique. We anesthetize the lingual, long buccal, mylohyoid, auriculotemporal nerve with the ID nerve. We go for more superior and we go for the mandibular condyle. So here we don't have bone touch. Sorry, we need to contact the condyle. I'm sorry. We need to contact the condyle. I made a mistake between this one and the echinocea technique. Sorry. So here we need to touch the condyle bone and then we go back a little bit and give. We go across the canine tooth of the opposite side. So that's how we give it to the above surface. We reach the condyle. Now, if the patient has trismus and we want to give him anesthesia, we need to go for the echinocea technique. The patient's closed his mouth and we don't have bony contact here. We go with the buccal sulcus along with the mucogingival junction of the maxillary mucosa. We go posterior aspect of the maxilla until the hub of the needle is adjacent to the distal surface of the maxillary second molar, but we need to be careful so we do not break the needle. If we find the ramus, we go more lateral or we move the lower jaw to the side being injected. Now we anesthetize the ID, lingual, mylohyoid nerve, and the lung buccal sometimes. So you see, we go all the way, we don't contact bone, we go for the notch, sigmoid notch. The mental nerve for the premolars and the soft tissues of the lower lip. Now the depth of the sulcus between premolar teeth, we advance below the apices of the premolars. The long buccal, so we anesthetize the buccal gingiva for the molar teeth. Now we can have buccal infiltration at the wisdom, for example, or regional block. We try to find the coronoid notch, that's where we try to give it, to have a block wise, okay? But mostly we use it as infiltration. For the maxillary, we can have an intraoral approach, the tuberosity and the greater palatine, or an extraoral. Now, for the intraoral approach, we go for the tuberosity, high in the plane of the distal surface of the maxillary second molar tooth, 45 degrees superiorly posterior and medial. We use a long needle. For the greater palatine, we go through the greater palatine foramen, advanced at an angle of 45 degrees superiorly to about 30 millimeters depth. For the infraorbital nerve, we can go intraorally between the premolars and the canine towards the infraorbital foramen. We try to touch it from the extraoral side, and this will anesthetize from the second molar to the central incisor with the infraorbital area and the lateral nose. For the extraoral approach, we go immediately at it, but we prefer not to use it because the patient will be afraid, like, why is the dentist going to give anesthesia below my eye? So it's kind of difficult. So the greater palatine, soft tissues from the palate to the foramen anteriorly to the canine region, we can go for palatal infiltration and gives us around 45 minutes of anesthesia. Now here we can give anesthesia. Now this is quite painful, so we can put a cotton Q-tip at the area to numb it before we can anesthetize, or we can go with the back of the mirror, applying pressure for a few seconds and then insert our needle. The nasopalatine for the incisors and the canines. Now, supplemental anesthesia, we can go for intraosseous. We make a buccal trough, and sometimes we have a specific system for it, or a small round bear to insert the needle there. we draw an imaginary line to go all the way into the tooth. We can go for intraligamental. We can keep going until we find pressure or resistance, and then we try to give. And the mandibular incisor is not very successful. Intrapulpal can be the last resort in patients with irreversible pulpitis to numb the pain a little bit. Now, the local anesthesia drugs, we have esters and amides. Now we use amides. Ester procaine is only used in patients who are allergic to amides. Esters metabolize in plasma, amides hepatic metabolism. Articaine has both hepatic metabolism and plasma cholinesterase metabolism. Now lidocaine, we can use it 2%, mepivacaine 2% or 3% solution, prilocaine 4%, articaine 4%, bupivacaine 0.25 to 0.75%, etidocaine 1.5%, levobupivacaine 0.25 to 0.75%, and ropivacaine 0.2% to 1%. Now, complication, we can go for nerve damage or loss of sensation, motor nerve paralysis, trismus, or intravascular injection. Now, we'll talk about these in the complications lecture that will be coming later on. Now, trismus would be due to the medial pterygoid. Systemic complications can be allergy, infection, toxicity, and drug interactions. Now, lidocaine, the maximum dose without adrenaline is 4.4 milligrams per kilogram, same as mepivacaine. Articaine, 7 milligrams per kilograms. Okay. Now, here we have another way of calculating it. Now, how much solution can I give? So first, we calculate the maximum recommended dose. Now, 2% of lidocaine means every 1% has 10 milligrams. So 2% means 20 milligrams. Okay? Now, 2% lidocaine with 1 to 100,000 epinephrine means 3.2 milligrams per kilogram per pound multiplied with 50 pounds equals 160. Okay. Now, so the maximum dose of lidocaine with adrenaline is 7 milligrams per kg. Now, let's say we have a 70 kilograms patient. We multiply the 70 by the 7, we have 490 milligrams. Okay? So, now, as we said, the 2% lidocaine have 20 milligram of lidocaine in the carpool. Okay? Now, we multiply the 20 milligrams of lidocaine by the 1.8 milliliters. So here 20 milligram per ml, which is the maximum amount in the carpool. This gives us 36 milligrams per milliliter. So now, the maximum dose over the local anesthesia drug, 490 over 36. So we can give up to 13.6. We can give up to 14 carpools for this patient. But we don't reach this number, of course, but this is the maximum dose that we can give. So I hope it was a short lecture and easily understood. If you have any questions, I'm always available, and thank you.